Hello friends, I am Professor Smita Jha from the Department of Humanities and Social Sciences, and I am discussing Michel Foucault's medical gaze in health humanity, which is indeed a very important aspect. And even in the previous lecture also, I defined some of the concept related to medical gaze. So, myth of the universal gaze. Foucault's medical gaze operates on the premise of objective universal clinical neutrality. And that is why I always say this is very, very important. The idea that a doctor looks through a purely scientific lens to see automatic truth. Intersectionality dismantles this myth by proving that the gaze is inherently trained on a specific baseline. The cisgender, white, affluent male body, and this I narrated in the previous lecture of mine too. The deviant body, anyone who deviates from this unstated standard, is not just viewed as biologically distinct, but often as pathological or atypical. Layered diagnostic blind spots because medical benchmarks were historically built on white male anatomy, the clinical gaze routinely misinterprets, misses, or completely misdiagnoses symptoms in women and people of color. In health humanities, learning about the medical gaze helps clinicians recognize when they are accidentally treating an illness as a purely mechanical problem, allowing them to consciously bring empathy and the patient's voice back into medicine. Modern technology has dramatically heightened Foucault's medical gaze, making it more abstract and deeply embedded in clinical systems than ever before. However, this digital transformation has also triggered a counter movement in medical education. Healthcare training programs are actively leveraging the medical humanities to teach doctors how to look past screens and see the human being. How modern technology changes the gaze. Rather than personal observation, the modern gaze is mediated through advanced algorithms, data streams, and digital interfaces. This has evolved Foucault's original concept in three major ways. Now, what are those measures? The data double, the EHR gaze, electronic health records, requires immense standardization and quantitative tracking. Doctors routinely spend significantly face-to-face time charting rather than talking directly to patients. The digital chart creates a data double of the patient. Clinicians risk evaluating this virtual profile of laboratory values and check boxes instead of the physical person in front of them. The algorithm gaze, AI diagnosis, artificial intelligence, and deep learning analyze massive imaging data, tissue samples, and EKGs to predict pathology faster than human perception. This shifts the clinical gaze away from human sensory deduction entirely. The diagnosis is generated inside an opaque black box algorithm separating clinical choice from patient narrative. The quantified self, continuous surveillance, consumer wearables, blood glucose sensors track real time biometrics continuously. The medical gaze is no longer limited to a physical clinic space. It follows the patient into daily life, converting biological existence into a non-stop stream of diagnostic numbers. Shifting from clinical gaze to compassionate gaze, ultimately, the primary goal of integrating Foucault into the health humanity is to push medicine beyond its technical boundaries. By learning to recognize when they are applying a cold analytical gaze, modern healthcare professionals are encouraged to adopt a more holistic, empathetic view that honors the patient's entire personhood, culture, and community. How doctors are taught to look past the medical gaze. To push back against this digital abstraction, medical universities and residency programs rely on the health humanities to recenter the clinical encounter. Some of these interventions include narrative medicine, pioneered by figures like Dr. Rita Sharon. At Columbia University, narrative medicine explicitly trains clinicians to listen to the illness narrative. The practice is student practice analyzing poems, short stories, and reflecting writing to build complex interpretation skills. And the goal is that they learn to recognize patient suffering, handle ambiguity, and explicitly understand a patient's personal history, directly countering the reductionism of clinical data point. The physical exam as ritual. Scholars emphasize the critical therapeutic value of the physical hands-on examination. The practice is that medical students learn that touching a patient, listening with a manual stethoscope, and validating their physical presence is an active social ritual. And the goal, this reminds trainees that a real person exists beyond the lab results and data charts, preventing reliance on purely remote digital monitoring. Visual art and museum training. Many programs partner with local art galleries to run a structured visual observation workshop. The practice is that students look at classical paintings or complex contemporary sculptures for extended periods and debate what they see. And the goal is that this teaches students to spot hidden details and biases in their own perception. It challenges them to separate passive looking from active, empathetic seeing, mapping cleanly onto how they observe an actual patient. Shared decision making and trauma informed care. Curricula are shifted from clinical paternalism to collaborative models of care. The practice is that trainees learned communication frameworks that invite patients to state their personal goals, social barrier, and distinct values. The goal is this explicitly repositions the patient as an active partner in care, shifting the dynamic from a passive clinical object back to human subject. Analyzing the physical exam as a ritual under Foucault's medical gaze highlights a deep tension in modern medicine. While Foucault argued that the clinical exam is a cold tool used to turn the body into a biological object, health humanities scholar such as physician author Dr. Abraham Verghese argue that the hands-on physical exam acts as a vital transformative ritual that can actually push back against reductionism. The physical exam under Foucault's medical gaze. To Foucault, the physical exam is primary mechanism through which the gaze operates. It is not a neutral act of healing, but an exercise of institutional power of surveillance. Now, what are those powers? The body as a map. Techniques like palpation, that is feeling, percussions, tapping, and auscultation, that is listening with a stethoscope, are designed to make the interior of the body visible. The doctor bypasses the patient's words to read the truth written directly on their tissue. Striping identity, the architectural and social staging of the exam, the sterile room, the paper gown, and the examination table functions to isolate the body. The person's social identity is temporarily removed so they can be processed as a clinical specimen. Hierarchical surveillance. The exam establishes a power dynamic where the practitioner is the active observer, the holder of knowledge, and the patient is the passive object being observed. Coming to the physical exam as a counter ritual, health humanities scholars reframe this exact encounter. They acknowledge that while the exam can objectify, its strict structure actually mimics an anthropological ritual of transformation. When done mindfully, it serves several humanistic purposes. First is crossing the threshold. Anthropological rituals signal a transition from one state to another, like a wedding or baptism. In medicine, the act of a patient confiding their vulnerability, undressing, and permitting another human to touch them is a profound crossing into a safe sanctuary space. Validating of suffering. When a physician lays hands on a patient to examine where it hurts, they physically validate the patient's subjective story. This physical touch provides comfort and connection that a digital lab value or an isolated CT scan profile cannot replicate. The placebo and therapeutic effect. The structured, rhythmic nature of the exam, the quiet listening, the systematic checking carries a therapeutic benefit. It signals to the patient that they are being intensely cared for, lowering anxiety and building a strong therapeutic alliance. The modern conflict, that is the gaze versus the eye patient. Today, the physical exam ritual is threatened not by the physician hands but by computer screens. As Dr. Varghese notes, modern medical technology has created the eye patient, the digital profile of charts, labs, and scans inside the computer. Doctors risk applying a purely digital gaze to the computer screen, completely bypassing the physical body on the exam bed. Therefore, teaching the physical exam as a sacred ritual in medical schools is a deliberate effort to pull doctors away from the digital screen, forcing them to look back at the actual human being. The phrase, the gaze versus the eye patient, perfectly captures the ultimate evolutionary tension between Michel Foucault's historical critique of medicine and modern digital healthcare. Coined by physician and author Dr. Avraham Varghese, the eye patient is the virtual data driven entity that lives inside clinical computer. When this concept is overlaid onto Foucault's medical gaze, it reveals a startling shift. The clinician's gaze has turned away from the physical human body entirely and fixed itself onto digital facsimile. The anatomy of this modern conflict unfolds across three primary layers. The dislocation of the gaze from tissue to pixel. In The Birth of the Clinic, Foucault explained that the medical gaze triumphed because it learned to look through the patient's skin into the physical organs and tissues to find organ lesions. The traditional gaze relied on sensory contact, the doctor's hands feeling a tumor or eyes looking at a rash. The eye patient gaze bypassing physical touch, the modern clinical gaze focuses on an electronic health record profile, tracking blood counts, potassium trends, and imagining scans like fluctuations in a stock market index. The locus of the disease is no longer the breathing body in the hospital bed, but the digital folder on the monitor. Well, the very famous line, which is the map is not the territory, that the reality is not the reality that we understand. Dr. Varghese frequently references General semanticist Alfred Krozebowski, warning that the map is not the territory. In modern healthcare, the eye patient is the map and the actual human being is the territory. This causes significantly systemic issues. The perfect eye patient. On the computer screen, the eye patient can look entire stable. Their checkboxes are filled out, fluids are mathematically balanced, and metrics appear optimized. The ignored human, meanwhile, the actual patient lying in the room may be visibly uncomfortable, terrified, or showing subtle physical sign of decline such as shifting skin temperature or breathing patterns that an automated lab value has not yet caught. Coming to the epistemic inversion, who tells the truth? Foucault argued that the medical gaze stripped authority away from the patient's spoken words and gave it to the doctor's observation. The eye patient conflict takes this one step further by stripping authority away from both the patient and the doctor's physical senses. Data over reality. If a physician performs a manual exam and suspects an issue, but the computerized scan or lab report says otherwise, the digital data almost always wins. The card flipped ward, medical teams often conduct clinical rounds away from the patient's bedside. They sit in isolated conference room, the bunker, debating the eye patient's digital metrics on the large monitors, while the actual human remains a passive placeholder down the hall. The health humanities response. Health humanities scholars emphasize that the eye patient represents the ultimate fragmentation of the self. To resolve this conflict, modern medical pedagogy does not advocate for getting rid of technology, which provides life-saving diagnostic precision, but rather for practicing dual sight. Doctors are being trained to use the digital gaze to analyze the eye patient, but to systematically return to the bedside using narrative medicine and physical touch to treat the human being. The gaze as cartographic tool creating the map. Foucault argues that the medical gaze does not simply observe a body. It actively translates that body into a scientific language. This translation is essentially process of map making, abstracting the flesh. When a patient describes their pain, the medical gaze filters out their personal history, emotional state, and social context. It reduces a complex human life into a standardized map of symptom, anatomical structures, and cellular behavior. So, the clinical map's purpose is that this map is highly useful. It allows medicine to categorize, predict, and treat biological dysfunction with incredible precision. The fallacy. Now, what are the fallacy? Confusing the chart with the patient. So, the core danger arises when clinicians commit a cognitive error. They begin treating the map as if it were the actual territory, treating the numbers. A doctor operating under a highly digitized medical gaze may focus entirely on correcting a potassium level on a screen or optimizing an EKG readout while failing to notice that the actual person in the bed is frightened, cold, or unable to swallow. The clean map versus the messy territory. The map is clean, orderly, and quantifiable. The territory, the human experience, is messy, unpredictable, and qualitative. When doctors prioritize the map, they choose the comfort of data over the complex reality of human suffering. The collapse of the territory in the digital age. With the rise of the eye patient, the digital facsimile of the patient inside the computer, the map has become completely unmoved from the territory. Epistemic dominance in modern hospital. If a physical body contradicts the digital map, the map is almost always trusted cover the body. If an MRI doesn't show a disc herniation, the patient's subjective experience of agonizing back pain is often dismissed as illegitimate. The disappearing patient, because the medical gaze can now access the map from anywhere via remote telemetry or off-site electronic records, the clinician no longer needs to enter the patient's physical territory at all. The patient is effectively replaced by their data. The health humanities remedy and the remapping the encounter says that health humanities scholars do not ask doctors to throw away their maps. Modern diagnostic maps are life-saving tools. Instead, the humanities train clinicians in critical cartography. Acknowledging the gaps, doctor must remember that a map by definition leaves things out, and a psychiatric diagnosis leaves out a patient structural poverty. Return to the bedside. Clinicians are taught to use the map to navigate, but to always look up and look at the physical terrain, the patient's face, their voice, and their touch to understand the true topography of the illness. Coming to classifying disease to localizing disease, and this says that in the birth of the clinic by Michel Foucault marks the transition from classifying disease to localizing disease as the precise moment the modern medical gaze was born. This epistemic shift fundamentally altered how doctors conceptualize pathology, transforming disease from an abstract botanical entity into a physical, anatomical reality anchored inside the human body. So, classifying medicine, the flat map of species pre-late 18th century, before the birth of the clinic, medicine practiced nosology, the classification of diseases into structured hierarchies of families. The abstract ideal disease was viewed as an ideal entity that existed independently of the body. A disease like the flu or tuberculosis was a coherent essence with a life cycle of its own. The patient as an obstacle in classificatory medicine, the individual patient's unique body was actually a distraction. The doctor had to bracket off or subvert the patient's personal constitution to see the pure species of the disease clearly. Sliding geography, illness was not fixed to an organ. A spasmodic malady could freely migrate from the stomach to the lungs while remaining the exact same disease. The clinical question was conceptual. What family of illness is this? Localizing medicine and the deep map of tissue. These are the various aspects, concepts of medical gaze and the 19th century shift. With the dawn of the clinic and the rapid rise of pathological anatomy, driven by pioneers like Xavier Bichat, the medical gaze learned to look into the body. Disease ceased to be an abstract entity floating across surfaces and became physically bound to three-dimensional internal space. Now, the sovereign autopsy, the definitive breakthrough, came from systematically dissecting corpses. By opening up bodies, doctors could correlate the symptoms a patient reported while alive directly with the visible, localized lesion left on their internal tissues and organs after death. The depth of the gaze. Foucault notes that the clinical gaze was forced to travel vertically, plunging deep from the symptomatic surface of the skin down into hidden corporate layers. The defining medical questioning permanently shifted from what is the matter with you to where does it hurt or where is the lesion. The individual objectified for the first time, discovering the true nature of an illness required probing the individual corpse. This made individual medicine possible, but it simultaneously finalized the objectification of the patient, reducing their human identity to an organic site of a localized breakdown. So, the health humanities view why this shift matters today. Health humanities scholars emphasize the historical shift from classifying to localizing disease was a double-edged sword. And under this sword, the first one is the triumph. It rescued medicine from mystical guesswork, allowing doctors to precisely pinpoint, target, and treat physical pathologies. Localizing a tumor, identifying an appendicitis, the crisis, it structurally served the connection between the illness, the patient's subjective personal experience of suffering, and the disease, the localized objective cellular malfunction. By tracing this history through Foucault, modern medical students learn that when they over-localize a problem, focusing solely on a specific damaged valve, a genetic sequence, or a single spot on an MRI, they are participating in a historical style of seeing that naturally decenter the human being. Viewing Michel Foucault's medical gaze as a cartographic tool transforms our understanding of a clinical diagnosis. It changes it from a neutral summary of facts into an act of aggressive map making. Just as a colonial cartographer draws borders to organize, control, and claim a wild landscape, a clinician uses the medical gaze to chart the chaotic, subjective territory of human suffering into an orderly, manageable medical map. So, the raw material, the chaotic territory, before the cartographic gaze is applied, a patient's illness exists as a sprawling, disorganized terrain of raw human experience. The messy narrative, it consists of vague fears, financial anxieties, physical pains, cultural taboos, childhood memories, and confusing timelines. And the problem is, to the scientific apparatus of medicine, this unmapped territory is illegible and unusable. It cannot be entered into a computer database, matched against a clinical trial, or billed to an insurance company. Coming to the cartographic processes, how the gaze draws the map. The medical gaze acts as a filtering grid, performing a specific map making operations on the patient's body and story. And under this category, the first aspect is standardizing the landmark. Now, the gaze stripes away local metaphors. If a patient says, "My heart feels like an overtuned guitar, strange snapping," the gaze flattens this poetic description. It maps it instead onto standardized coordinates, tachycardia or arterial fibrillation, isolating the topography like a topographic map that completely ignores trees and cities to focus exclusively on elevation. The medical gaze ignores the patient identity. It focuses strictly on organic topography, the height of a white blood cell count, and the size of a nodule or the voltage of a cardiac wave, creating borders nosology. The gaze draws sharp, rigid lines around fluid human experiences. It dictates exactly where normal baseline terrain ends and where the foreign territory of pathology begins. For example, establishing a strict numerical cutoff line for hypertension or diabetes. So, the power of mapmaker, Foucault's central point about power, is deeply embedded in this cartographic analogy. He who draws the map holds the power. Silencing the local. Historically, European mapmakers ignored the names and boundaries used by indigenous population, replacing them with their own language. Similarly, the medical gaze replaces the patient's native understanding of their own body with highly technical Latinate medical nomenclature. The illusion of completeness. A map always creates the illusion that it represents the entirety of the land. When a doctor holds a highly detailed anatomical map like a 3D CT scan, the sheer precision of the data tricks them into believing there is nothing left to learn about the patient's suffering. So, the health humanities counter approach critical cartography. Clinicians are taught to practice critical cartography. Their study of how maps are never purely objective and always leaves things out. Medical students learn that a chart is merely a sketch of disease, not a complete portrait of the person. By understanding that the gaze is just a cartographic tool, doctors learn to use the map for navigation while looking up to speak with the person actually living in the territory. With this, I conclude the discussion for today. Let us meet in the next lecture. So, till then, thank you.